Now, this second part of lid pathology is on eyelid histopathology, and I'm going to describe individual slides of histopathology for you. The first one is a Chalazion, and you know what is a Chalazion? It is a mass in the deeper posterior lamella due to granulation tissue formation in one of the sebaceous glands which are inside the tarsus. And the etiology of this condition is metaplasia of the epithelium of the ducts of the meibomian glands. And by metaplasia, we mean this is a basic pathological term that we described in the lecture on general pathology, and it means the change of one type of epithelium into another type. The non-keratinized epithelium covering the ducts of the meibomian glands becomes a keratinized one, and this leads to obstruction of the gland drainage with formation of a granulation tissue. And I'm sorry, granulomatous inflammation, not granulation tissue. I'm sorry. Again, it's with formation of a granulomatous reaction. And this granulomatous reaction is zonal in nature, meaning it is not involving the whole meibomian gland, but part of it. There are clear centers with lipid that is dissolved, infiltration by polymorphonuclear lymphocytes, plasma cells, lymphocytes, and it is a non-specific type, and there is a multi-nucleated giant cell preponderance with other findings like asteroid bodies and Schulman's bodies. Now again, Chalazion is a chronic granulomatous inflammation in one of the meibomian glands. It's zonal in nature, occurring around a clear center with dissolved lipid. And this is the caseated-like material that comes out when you open a Chalazion and is infiltrated by polymorphonuclear leukocytes, plasma cells, lymphocytes, and there is an infiltration by multi-nucleated giant cells, but these are non-specific. And there are asteroid bodies, which are acidophilic in nature, and Schumann's bodies, which are laminated. I'm sorry for the spelling mistake, it's SCH. Now we describe a Xanthelasma, and a Xanthelasma is deposition of cholesterol salts, a variety that occurs like fat in histology. And here we have the plaques of cholesterol salts that appear like a patch which has a dirty white to yellowish coloration. This may be due to hypercholesterolemia, and hypercholesterolemia might be a congenital variety or due to dietetic reasons. And once you see these, you should check the cholesterol level, triglyceride level in your patient. And on examination under the microscope, we find foam cells in the superficial dermis containing lipid material, and may occur in the form of clusters around blood vessels that involve the vessel wall. Here are the foam cells, and here the deposition around the blood vessels. One important thing here is that we said that the deposition is in the superficial dermis, and this means you have to go a little bit deep when you excise them, otherwise the excision will be partial, and the patient would consider this recurrence. Although it's not recurrence, it's imperfect excision. Now we come to a dermoid cyst, and we describe dermoid cysts in the orbit, and these are formed of lining of keratinized epithelium with dermal appendages in the walls like hair follicles and sebaceous glands. A sebaceous cyst is a cyst in one of the sebaceous glands of the hair follicles. And the lining is with swollen cells with indistinct borders, with palisading in the outer layer. These are the swollen cells, ballooned, and the lining is with an outer layer of palisading. The cavity contains an amorphous eosinophilic material. It is removed during the processing of the slide. Ductal cysts or hydrocystoma, these are very common. They are cysts in the ducts of the sweat glands with double layers lining with a myoepithelial outer layer. So double layers, the layer inside is cuboidal and the layer outside may be myoepithelial in nature, which is the contractile type of cell that when contracts leads to evacuation of this eccrine type of glands. Now, a dermolipoma, or it's a solid dermoid with many fat cells, may contain stratified squamous epithelium or appendages, and each of these fat cells is a very swollen one filled with fat that is washed out during the process of preparation with the nucleus compressed to the periphery. And when you see a picture like this, you should differentiate it from a prolapsed lacrimal gland when it is on the lateral side. But here it's on the medial side. This is the punctum, and this is the medial canthus, and this is the nose. So this can never be a lacrimal gland prolapse. Now we come to Molluscum contagiosum, and this is a viral disease where you can see a sessile, hemispherical, whitish nodule on the skin. If you open it, you find a cheesy material that is flooded with the virus particles, and thus it is very infectious. On examining under the microscope, it looks like an orange with the lobules having an acanthotic epithelium. And we said that acanthosis means thickening of the squamous cell layer, surrounding an intracytoplasmic xenophilic inclusion bodies, which are larger near the superficial epithelium. Lobules of acanthotic epithelium. And then we come to seborrheic keratosis, which is not a very common thing, but it is a type of keratosis with seborrheic character, with basal cell acanthoma, papillomatous configuration. As you can see, there are sort of dips in the skin filled with keratin, making a sort of keratin cysts with marked hyperkeratosis. A lot of keratin with cysts filled of keratin as well, and it looks like this, a plaque with hyperkeratosis, dark coloration, and seborrheic in character, meaning there is this sort of luster due to secretion of sebum or oil. Now, a sebaceous gland adenoma, an adenoma that occurs in the sebaceous glands of the hair follicles. It may look like a chalazion, and you may excise it, and on excising it, you will never find cheesy material inside. And being a gland It's formed of lobules, and the cells look like a normal sebaceous gland, but with excessive proliferation. You may find fat cells inside and transitional cells. So it is a sort of a benign proliferation of the normal structure of the sebaceous glands to form an adenoma that clinically or macroscopically looks like a chalazion. That is why we always say, if you open a chalazion, you may have a biopsy if you suspect this is a very fleshy tissue, so as to confirm the diagnosis. The diagnosis is confirmed microscopically, and of course, in this condition, there is a recurrence. A chalazion never recurs. It may occur in another area, but in the same place, if recurrence occurs, this is a proof that this is not a chalazion. Now, a sebaceous gland carcinoma or adenocarcinoma is just like the same type of cells, but not arranged into glandular appearance with malignant characters like hyperchromatosis of the nuclei, multiple nucleoli, excessive mitotic figures, and so on. And these lipid cells occurring everywhere. Now, a cavernous hemangioma that we described in the orbit may occur as well in the skin. And this is, as you know, is a hamartoma, where there is anomalous tissue formation in the same locality with large blood-filled spaces with endothelial lining and fibrous septa in between. Cavernous hemangioma, same with RBCs in this center. Capillary hemangioma in a child, which is evanescent, that may disappear spontaneously, as we said before, and here it's causing an S-shaped deformity of the lid margin. And you have to treat, of course, not waiting for disappearance of this condition, as covering of the pupil here may lead to a condition of amblyopia. Here the spaces are smaller, and interstitial tissue septa are more abundant with endothelial lining and blood vessels inside. Now we come to nevi, and when we describe a nevus pathologically, a nevus is a benign melanoma. It's an area of discoloration and elevation, and there are three types: the junctional, the compound, and the intradermal, in addition to the blue and nevus of Ott. It's not epidermal, compound, and intradermal, which is easier to remember. No, it is junctional, compound, and intradermal. And bijunctional is the flat type where the pigment cells occur at the junction of the epidermis and dermis. If it occurs in the hypodermis and junctional as well, this is called compound, and the intradermal is the one occurring in the dermis. So it might be junctional, epithelium and dermis, compound, epithelium and dermis, the junction with dermal component, and intradermal is the dermal one, in the dermis only. So let's say epidermis, epidermis and dermis, and dermis. But this is not epidermis only, it's at the junction of the epidermis and dermis, so it's called junction. These all are brown. This one has low malignant potential. This one resembles a malignant melanoma in being more branched, but it is benign in nature. And the dermal one, being deeper, looks black with no malignant potential. So the three main types are the junctional, compound, and intradermal, and the only one with a malignant potential but a low one is the junctional. And then the deeper dermis component is again flat but blue to gray in color. The deeper you go, the bluer you get. It's just like the sea due to the optical phenomenon of birefringence, where the blue color is the one received by the human eye when you look at it. And when it is deep in dermis, it's blue and it's flat. And finally, if it is extensive, it's called the nevus of Ota. Nevus of Ota. So the junctional type is flat and brown. The compound type is looking almost the same like the junctional, but maybe more branched and more extensive. And this one is darker and elevated. Flat and not elevated bluish in color is the blue, and the Ota is the extensive one. So this is the junctional. This is the compound, junctional and dermal, and this is the dermal one. This is brown to black, brown, and this is darker, very dark, may look black, and elevation increases with transformation. The junctional is flat, the compound is slightly elevated, and the dermal is elevated. The junctional nevus, not elevated, brown in color. A compound nevus is elevated, and an intradermal lesion is very elevated. If it is deep in the dermis, it's blue, and if it is extensive dermal blue nevus, we call it the nevus of Ota. You can see here the melanocytes seen in the junctional area, here in the junctional and the dermis, but here only in the dermis. The very deep one is the blue, and when it is extensive is the Ota. Please try to teach yourself the difference between the junctional and the compound, because saying epidermal, compound, and dermal is not a right thing, although in the exam, many of you say this. This is an example of conjunctival episcleral benign melanoma, and this is a nevus in the fundus. This is the blue nevus. And this is the nevus of Ota. Now, sarcoidosis, we described this before. It's a granulomatous reaction, non-caseating, and I remember saying that non-caseating is the old term for comparison of the previously, historically, very common lesion of tuberculosis, and it's characterized by multiple multinucleated giant cells with asteroid bodies and Schauman's bodies, just like a Chalazion, but here no caseation. And this is a granulomatous specific inflammation. Now we come to basal cell carcinoma, and this originates from the basal cells. It has three types, either nodular, ulcerative, or morphia type. Nodule looks like a nodule, ulcerative type leading to ulceration, and morphia type looks like an infiltration, just like in this case. The cells resemble the basal cells with peripheral palisading. They are pleomorphic and atypical, and this is not a malignant tumor. It's a locally malignant tumor. That means it does not spread distally. It invades only locally. This is the nodular type, as you can see. All these are the nodular types, and this is the morphia type. Squamous cell carcinoma occurs from the squamous cell layer of the epidermis, where the epithelium is fully replaced by malignant cells invading the basement membrane into the dermal layer with sometimes distal spread. And in the conjunctiva, you are going, or probably you have already studied, the Bowman's disease, which is the carcinoma in situ. That means carcinomatous changes in the squamous cell layer, not invading the basement membrane. It's the pre-malignant condition. Now, finally, we come to melanoma. And by melanoma, we mean malignant melanoma. No more term like benign melanoma or malignant melanoma. When we say melanoma, that means a malignant one, and the other one is called nevus. It may occur in any pigmented tissue, and thus it may occur in the skin of the eyelids. These are the melanocytes that have proliferated into melanoma cells. And this is melanoma in the choroid, and you can see how elevated it is by the contouring of the blood vessels. These are the malignant cells, and there are two types, spindle A and spindle B, and the epithelioid. The spindle A and spindle B are both like a spindle, elongated, and the epithelioid are more globular in shape. And I'm going to leave this in description to my colleague who is teaching the melanoma in the choroid. Thank you very much.